Thank you for all those who are not very hungry and still back in the room. The dining area is completely packed. I just saw that. So we heard a wonderful conversation by Dr. Jabbar on Glargine 100. But soon following that is my conversation where I'm going to tell you probably Glargine 100 is not the best and we have something better. So transforming diabetes care with the second generation basal insulins. Quickly, I'm going to go through importance of insulin initiation and titration, the optimization of insulin therapy with the generation 2 basal insulins, and some practical considerations on the use. Landmark study was a large first-scale longitudinal prospective observational real-world study to investigate the management and complications of type 2 diabetes across India over a period of 3 years. And a lot of important learnings we got from the landmark study. 63% patients of type 2 diabetes are uncontrolled, more than 7% as we've known. Less than 1 in 4 Indians with established type 2 diabetes take insulin, so insulinization continues to be poor in our country. Average A1C at which insulin is initiated was about 9.2%. And this is what we found from about 6,200 eligible subjects across 382 sites on all parts of India. The problem is insulin initiation the answer? What really happens after that? So even after insulin initiation, reaching the A1C goal has been elusive. 8 out of 10 patients fail to get to control. This was a recent paper which was about titration inertia in India. I was happy to be part of the author block, which discussed the best practices and tools for titration of basal insulins. Expert opinion from an Indian panel via the modified Delphi consensus method, which was the first consensus document generated by Delphi method on simplification of basal insulin. What we realized was the average optimization dose of basal insulin in our country, or rather in Asia, remains at about 18. Most of us were programmed to start insulin at 10 units flat when it was basal or glargine, 10 to 12, but we never really optimized the use of basal insulin. Maximum dose up to which basal insulin is uptitrated should be 0.5 units per kilogram is what the expert consensus was, but the average dose is about 18 in Asian countries, which is lower than what is ideally required. Now importantly, all of you will understand that the initial period when you start insulin and titrate is the most important period. After the first 10 to 12 weeks of titration, we get into more of a lazy zone. Neither the physician titrates much, nor does the patient. It's almost similar to the initial overs in any cricket match, any short form of cricket where you're getting your super overs and you want to do the best. So your titration period is similar to that. 80% of the maximum treatment effect occurs in the first 12 weeks. Early response predicts the long-term glycemic control within 12 weeks. The A1C levels, what you achieve, lands up being maintained at 24 months. Also, if you get hypoglycemia in the early period, unfortunately that early hypoglycemia in the titration period doubles the risk of future hypoglycemic events, and early hypoglycemia increases the risk of treatment discontinuation, and all of us would have faced that. The patients experiencing hypoglycemia in the first few weeks of starting are not too keen to continue. So the larger point being that in the journey of insulinizing your patients, the first few weeks are extremely important, which is what decides where you reach on the target, how long are you able to maintain the durability, the safety part, and the continuity. There continue to be barriers to insulin initiation and intensification. These are barriers that we all need to overcome and in fact be aware of first. You have patient-based barriers that we have already spoken about. Believing that insulin is a personal failure, lack of confidence in titrating the dose, lack of education and support. Well, there are multiple patient support programs and we shouldn't, after all these years of having some wonderful insulin, still be talking about patient-based inertia. We have to overcome that. You look at the healthcare practitioners' point, that is us, lack of time and support still continue to be a problem in busy practices, especially primary care. Scarcity of resources, inconsistent or inadequate treatment approaches. Do I start with 10 units? Do I start with 0.1 unit per kilogram, 0.2, what to go about, basal, premix? A lot of questions and then different recommendations creating more confusion. And then of course there are certain concerns which are held both by the patient and the physician, like hypoglycemia, complex titration regimens and so on. So balance glycemic control versus hypoglycemia risk, and that's important, and which is where the second generation basal insulin does far better than the first generation. If the first generation has been considered the gold standard, then well, we have platinum here. The second generation basal insulin is helping us find a balance between A1C reduction and avoiding hypoglycemia, safer titration and maintenance period, minimal weight gain, flexible dosing does allow you +2 to 3 hours flexibility, stable and prolonged action, genuinely flatter and 24-hour acting insulin, less glycemic variability, effective and sustained control, and less overall and nocturnal, importantly nocturnal hypoglycemia, and I'll be sharing some data. So there is strong evidence for glargine 300, and when you look at it, there are multiple studies, the PK/PD studies, the randomized clinical trials, the real world data. We have two set of comparisons for glargine 300. One, of course, comparing with glargine 100, which has been considered the gold standard. And then the other set comparing with the other second generation basal insulin, which is degludec. So to be fair, good comparisons, both with the gold standard and with the other new comparator and competitor. So addition program, the objective and design, this was in comparison of glargine 300 to 100. To assess the clinical efficacy and safety of glargine 300 versus 100, randomized 1:1 open label parallel group multi-center of phase 3 studies. The addition program was built with similar study design across its various trials to confirm the results. So you had patients who were randomized to either glargine 100 or 300, 6-month duration with another extension period for 6 months. What they wanted to show was non-inferiority of glargine 300 to glargine 100 in A1C reduction. So when you have a new insulin, they wanted to just show that it's non-inferior to the existing gold standard and see whether you're getting any benefits. So glargine 300 versus glargine 100 use may lead to reduced hypoglycemia during the titration period. So when you're looking at the data for both the type 2 and the type 1 studies in the addition program, you're seeing less risk of hypoglycemia for glargine 300, especially in the titration, which is the first 12 weeks of time. And then you're seeing this benefit for nocturnal hypoglycemia reduction and for overall any time of the day hypoglycemia. So on both these fronts of hypoglycemia, glargine 300 doing better. This is a patient level meta-analysis of the addition 1, 2 and 3 studies, which showed that in terms of A1C over the 12-month period, and you can see the trajectory both for the green and the purple lines, that A1C is coming down, but over a 12-month period, you can see that glargine 300 is doing a little better in terms of lesser A1C as compared to glargine 100. So almost similar, slightly better A1C at the 12 months. So what's the difference? The difference is 42% lesser nocturnal hypoglycemia for glargine 300 and 23% lesser anytime hypoglycemia, and also less weight gain with glargine 300 versus glargine 100. We then moved to look at the BRIGHT study, which was another landmark study because everybody was awaiting this before it was released. You wanted to see the comparison between glargine 300 and degludec. Patients who were more than 18 years of age, type 2 diabetes duration for more than a year, A1C between 7.5 to 10.5, BMI 25 to 40, OAD use with or without GLPs on stable dose, and no prior insulin use. So these were insulin naive patients who were then randomized to either receiving glargine 300, whose A1C was between 7.5 to 10.5, or degludec 100 once daily. And you had the titration period for 12 weeks, a maintenance period for 24 weeks, and then a follow-up safety period of a week. What did we see in the BRIGHT study? Comparable A1C reduction again. So your glargine 300, in terms of A1C reduction, was found to be comparable to degludec. And you can see again the trajectory of A1Cs coming down and then staying well throughout. You're also looking at the A1C from baseline and week 24, starting from 8.6, 8.7, by the end of the study coming to 7. So both the insulin arms doing well in terms of A1C reduction. Then again, where is the difference? So the difference comes in hypoglycemia. So BRIGHT study showed lower hypoglycemia for glargine 300 versus degludec 100 especially during the titration period, which is the first 12 weeks. And let me remind all of you the importance of titration period, because that's where the maximum action happens. If you miss the bus then, your patient is probably stuck onto a lower dose or afraid of hypoglycemia, or still at an A1C of 7.9 or 8.1% in spite of starting insulin. So which is where the titration period where you can titrate to optimize is so important. This also, there is data showing lower variability. So you're looking at the PK data, and you can again see on the graph on the left, 22% greater insulin peak with degludec versus glargine 300. So the sugars are going higher there. You're also looking at the pharmacodynamic data on the right side, the glucose infusion rate, and you'll appreciate the flatter dots in green as compared to degludec in the purplish blackish spots showing glycemic variability. So you will get more consistent and constant flow of glargine 300 as compared to the other insulin. You look at one of the other studies which looked at patient-reported outcomes and quality of life, which show that initiating glargine 300 in insulin-naive patients showed overall improved treatment satisfaction and reduced perceived frequency of both hyper and hypoglycemia. So when you look at the first one, which is the quality of life, and you can see at baseline 3 months, 6 months and 12, in all of these over a period of time, the treatment satisfaction is improved. And when you look at fear or change in treatment satisfaction, again from baseline to week 24, the purple lines telling us that by the end of 24, every treatment satisfaction has improved with glargine 300. Finally, some practical considerations about glargine 300. What do we initiate with? So a little de-learning, need not be 10 units, move to 0.2. So if your patient is 80 kgs, look at starting with 16 units and then titrating it, and titration is important. It can be given any time of the day, but around the same time. Typically with this safe, flatter insulin, your OADs can continue, including sulfonylureas, but keep a watch, you may have to titrate that. It can be safely titrated once in 3 days, or even once weekly is good enough. You can go up to 0.5 units till you achieve or don't achieve control, then you may consider a basal plus or any other regimen. Less variability, duration is more than 24 hours, low hypo, low weight gain, and safer titration. So in today's challenging times, it's extremely important to have something like this in our hands. The device also makes a difference for those of you who haven't gotten your hands onto this. There's a dedicated cartridge, there's clear dose display and flexible dose selection, including 1 unit titration. So between 4 and 6, the line is 5, or between 12 and 14, it is 13. Simple dose delivery, and let's understand this is more concentrated unit insulin, right? So it's 300 units per ml. And hence, the amount of liquid that you're injecting, especially for higher doses like 30 units, 35 units, is much lesser than when you would do with a 100 units insulin. So the amount of discomfort or pain that the patient has also goes down, because this is more concentrated and lesser fluid going inside the patient's subcutaneous area. So which is where the advantage of this pen comes in, and it has total 450 units, so 1.5 ml. So let me wind up by saying that this one, safe during titration and maintenance period, effective and sustained glycemic control, improved quality of life, flexible dosing, reduced weight gain, full day coverage, and once daily injection, and of course less painful injection. That's glargine 300 for you. With that, I thank you for being here. Thank you, chairs.
Thank you, sir. Thank you for the excellent presentation, and congrats. You were very clear with how, when, and how to move forward with regard to usage of second generation basal insulin comparing with the first generation. So we'll move on to the next topic.